So good morning, everybody. Apologies, we're just starting a few minutes late. We have got lots of messages from people stuck in traffic on Hale Street and Southeast Freeway, and typical Brisbane, isn't it? But welcome. My name's Patsy Yates. I'm Executive Dean for the Faculty of Health, and I'm delighted to see you all here, both in person and our folk online, for our first of our Real Health lectures for 2024. So, and I've got the pleasure of moderating the session today with this panel, who I'll introduce in a minute. But we do really appreciate you joining so early to come to hear this discussion. We think it's a really important one at this time. And I would like to extend a special welcome to QUT's Deputy Vice-Chancellor, Indigenous Australians, Angela Leach, who is on her way. So she's not here now, but she is on her way. But I wanted to make sure that I acknowledge Angela's contribution to and support for our faculty and our Indigenous strategy within our faculty, along with Professor Jodie Curry, our Professor of Indigenous Practice, sitting at the front table here, who's also helping us to develop a dedicated Indigenous strategy to address the health issues for our Indigenous communities. So in keeping with the spirit of reconciliation, I'd like to acknowledge the Turrbal and Yagara people as the First Nations owners of the lands where QUT now stands, and pay respects to their elders, laws, customs and creation spirits. And I recognise that these lands have always been places of teaching, research and learning. And I want to acknowledge the important role Aboriginal and Torres Strait Islander people play within the QUT community. And to that end, I'd like to just now play a welcome to country message. Thank you.
Balka be Balka, welcome in the language of the Yagara people. We acknowledge the Turrbal and Yagara peoples as the First Nation owners of the lands of where QUT now stands. For thousands of years, the Turrbal and Yagara people have gathered along the banks of Maiwar, the Brisbane River, to share their knowledge and stories. We pay our respects to their elders, laws, customs and creation spirits. We recognise that these lands where QUT now stands have always been places of teaching, researching and learning. We acknowledge the important role Aboriginal and Torres Strait Islander people play within our QUT community. From Moreton Bay, inland as far as the Great Dividing Range near Warwick and Toowoomba, as far north as the Caboolture River, including the lands around Brisbane City, Meanjin. Yura Yura Yinala, Balka bi Balka, Nganguru Maramakura Nganyabirali Manyabayam. Welcome to the traditional country of the Turrbal and Yagara people.
Okay, so just a few housekeeping items before we get started. They will serve breakfast very soon, so hopefully they won't interrupt as we get started with the presentations this morning. But just a couple of housekeeping items. In case of an emergency, please follow the QUT staff members to the stairs just outside the room here on the right, and restrooms are located outside the doors and right down the end of the building here. If you wish to post this morning about the event, please just use hashtag QUT Health. And for our online audience, feel free to send any questions through in the Q&A panel there, and we will address those at the end. So thank you, and welcome, Angela. We know the traffic's bad, so thank you for coming along. So at this Real Health Lecture Series, we started in 2021, and we really felt, and it was a time, of course, when we're right in the thick of the pandemic, but we recognised that we needed to provide more and more forums to have critical discussion about key health issues in our community. And we felt that as an academic community, in partnership with our colleagues in health and in other parts of society, we needed to really lead some of the discussions and try and identify solutions that we can work in partnership with the community and with Queensland Health and private health sectors to deliver better outcomes. So in keeping with that, and we've had a range of lectures on a number of different important topics over the last few years, but today we're particularly focused on health workforce. And we typically, like today, bring together leaders in health workforce, in health issues, and talk about what are the challenges and opportunities. And we take on board some of these to feed this into our research programs, our other activities that we do in our courses. So we're looking forward to hearing this discussion today. And it's particularly timely, of course, with the release of the Universities Accord 2 weeks ago. There's many issues that are brought up in that accord that do touch on some of the challenges in the health workforce and preparation of the health workforce. And we're just, as a university, really digesting some of that at the moment, trying to think through what are the implications and which parts of that, and how might we implement some of those reforms that are proposed in that accord document. And we're going to hear about some of that today, I think, some of the perspectives, particularly on how we support our students to complete their programs and to be retained in the health system. So, and the discussion today, we've also got some of our key leaders from the Faculty of Health who are going to talk a little bit about the work that they're doing and how we're trying to prepare graduates who are prepared for the workforce of the future. But to kick off today, we have a great pleasure in introducing our first panellist, Dr. Jo Aquino, who is Assistant Deputy Director General, Workforce Strategy, Clinical Planning, Service Strategy Division in Queensland Health. Jo's worked with numerous public and private sector organisations in the areas of workforce optimisation, organisational design, workforce planning, change management and performance management. And his area of focus is on large-scale transformation projects where organisations are looking to change the way they operate or how they're structured in order to meet the needs of the customer. So Jo's approach to work and transformation is informed by his PhD in the field of psychology, which focused on changing human behaviour using self-determination theory. So as Assistant Director General at the moment, Jo's responsible for leading the development and implementation of strategies, policies and collaborative initiatives to source, attract, build and retain workforce resources and capabilities to ensure the continued provision of safe, responsive, quality and sustainable health services in Queensland. So welcome, Jo. I'll just introduce other panellists and then we'll ask Jo to give our presentation, our beginning presentation. So our other panellists, we have Associate Professor Andy Hale, who's second from the end down there. Andy's been a hospital pharmacist for 25 years with a directorate role in Central and North West London Mental Health Trust in 2000. Before he moved to Brisbane in 2003, where he's worked at PA Hospital and Royal Brisbane and Women's Hospital. And his roles have included Senior Pre-Admission Clinic Pharmacist, Surgical Team Leader, Assistant Director for Clinical Services, and he's acted as Director of Pharmacy at both hospitals. And he came to work with us at QUT in 2022, and he is very involved in a range of different programs around pharmacist prescribing. So thank you, Andy, for joining us. Amina Tariq, who's third in the middle there. Amina is Associate Professor in Digital Health and is Course Coordinator for QUT's Graduate Certificate in Digital Health Leadership and Management within the School of Public Health and Social Work at QUT. Amina does research, consultancy and projects and delivers a range of our education programs at QUT that aim to promote effective use of digital health technologies for high quality, safe care. So welcome, Amina. Our next panellist is Christine Morley, who's second from this side. Christine is Professor and Head of Social Work and Human Services Discipline within the School of Public Health and Social Work. She's also co-leader of the Access to Justice program of research within QUT's Centre for Justice. Christine's passionate advocate for critical social work and has published extensively on the application of critical theories to social work education and practice. And she's also recognised as an expert on critical reflection and has published extensively in that area. And last panellist right down the end is Associate Professor Suzanne Williams. Suzanne is Nurse Practitioner and Course Coordinator of our Master of Nurse Practitioner program at QUT. She's a broad scope of clinical practice which encompasses the nurse practitioner meta specialties of emergency and acute care, child and family health and primary health care. And Suzanne's career as an advanced practice nurse has spanned a diverse range of tertiary and advanced practice nursing roles in both the public and private health sectors. And her program of implementation research is focused on expanding the scope of advanced practice nursing workforce to improve consumer access to quality care across Australia. So I'm now going to hand over to Jo to set the scene for us today. Thank you.
Thank you very much. And Thank you for the opportunity to be here this morning. I too would also like to acknowledge the traditional owners of the land on which we're all here today and pay my respects to elders past, present and emerging, and also acknowledge anyone of First Nations origin here in the room today and your connection to country. So health workforce, you'd have to be living under a rock to know that this has not been a massive topic of conversation across all levels of government, across the whole health system, not only here and abroad. So it's a really important conversation. And I guess I just want to set the scene with also the conversation we're going to have today and the questions is that we really need to do things quite differently. And we're looking, see if it's on. If it's on, yeah. We need to do things differently and we need ideas, and places like QUT are the perfect environment to really start to help us push health in a different direction. So I'll just click to the next one. There we go. Why don't we start with this image, a bit of a test for everyone since we're at uni. Does anyone know who this image depicts? Who is this? Yeah, it could be. Does anyone know who it is from Greek mythology? Sisyphus, that's right. So there's some Greek mythology buffs in the room. So very quickly around Sisyphus, Sisyphus was a pretty crafty character. He escaped death twice. On the second time, Zeus was particularly angry with him, so therefore sent him to the underworld, where his punishment was to roll a rock up a hill. But the way that Zeus twisted a bit is he made sure that when the rock got near to the top of the hill, it would roll back down again. And the catch was that if he could get it over the hill, he would be able to go back to the world of the living. He's still today rolling the rock up the hill only for it to roll back down again. So this example, this story has been used by academics, philosophers, poets to describe the human condition. But I think, as people have already indicated by those in the room who said it's us, is that's a very interesting metaphor for us in health. And the reality is, the message here is if we continue to do things and expect our health system to respond differently by doing things, same things over and over again, we will be like Sisyphus and the rock will roll back down over us. I'm not sure how much worse or challenging things need to get before we actually make the change. I would hope that we're very close to that so we can start moving forward. So let's talk a little bit about health workforce. There's only one slide that's really downbeat and depressing. It's this one. I could talk to you about the workforce data and the workforce stats around the lack of healthcare workers globally. I suspect you would be aware of that. One thing that I did want to pull out is some really important points, especially for us in Queensland Health, of some of the phenomena we're seeing. So it's a given that there is a workforce scarcity of health workforce. But we also need to consider some of the contextual factors that are playing into this. So we are seeing a decrease in full-time employment. So in fact, and this is even before COVID. So if you look at our midwifery workforce from 2013 through to 2019, so pre-COVID, the average hours have decreased by around 9.5 hours a week. So people have been choosing to do other things other than work full-time for quite some time. We're also seeing when people come into Queensland Health, it's no longer on full appointments. People are coming in at 0.5, 0.3, 0.6, 0.7, and a lot of those choices are quite deliberate. So we have to make sure that we sometimes feel in health that we are a unicorn. We're very different to other sectors. And yes, we do have a lot of things that make us very different, but we are not immune to global trends in relation to workforce thoughts and workforce expectations. Nurses, doctors, allied healths, they still are open to what the big changes of people are expecting inside workforce. The other thing that I'm sure you'd be acutely aware of is that health courses across the country, and in particular in Queensland, are seeing, we say it says reduced enrolments, but I guess the main point there is it's not as strong across the board as what it used to be. And we're seeing that with our engagement with our university partners. And that's quite concerning, because when we look at our clinical workforce, that is our pipeline inside the health sector, and in particular Queensland Health. Moreover, when we look at enrolments, and this is through conversations that I've had with the deans and the VCs, is that the students are also studying differently. So I'm not going to guess the age of the people in the room, but I'll just give my example. When I went to university, the goal was to enroll full-time, work part-time. If I looked like I was going to fail a subject, which I came very close to in first year anatomy, I pulled out before financial penalty and academic penalty, and it just meant that second semester the following year I had to do 5 subjects. And that's the way that we did it. The reality is the students today, given the challenges in relation to cost of living and financial pressures, is they're not studying full-time either. So not only are there less of them, they're also coming to us, 20 to 30% later in time, because it's taking them longer to complete their degrees if they do. So that's a really interesting dynamic. We also have a large number of the workforce close to retirement in Queensland Health. And then we have this unbelievably increased competition between the states, territories and countries. And that is playing out at a national level, although we are trying to work with the Commonwealth across the jurisdictions to try to come up with scenarios where we all benefit. And then you may be aware we are also undertaking the largest investment in our infrastructure program in Queensland Health's history, with upwards of 2,000 beds coming online by 2028. And those beds require both clinical and non-clinical workforce. So I just wanted to set the scene on top of the scarcity around the point here is that we really need to think about how we respond to these problems. And going with old or methods that we've used in the past, there are some validity in that. We do need to do things differently. Before I go into what we're doing in Queensland Health quite quickly, I think it's important to note that there's been a lot of workforce strategies. The NHS released theirs September last year. Victorian Health released theirs about a month ago. There's workforce strategies out everywhere. And they all say the same thing, retain, train, adapt new ways of delivering. And they are 100% the pillars that we need to fully focus on. And to be honest, the Queensland Health strategy is exactly the same. I think, and probably it's underpinned a little bit with my background, is that I actually think that we need to have fundamental changes at the foundation of what I would call the key enablers that we need to really unlock to allow for these strategies to actually be implementable and also stick. Because going through a workforce strategy and ticking off the box to say, we've done this, we've done that, I don't know if that is going to get us to where we need to go. We need to fundamentally change the working environment. And so I want to take you through a few of those. So the first one is employee experience, or whatever you'd like to call it. But the reality is, if we look at Queensland Health, we are not representative of what a modern organisation looks like. And what I mean by that is that modern employees coming to us have expectations about what the employer and the employee contract looks like. 20, 30 years ago, it was a simple formula. I, as the employer, offered you a job. I said I would pay you every fortnight. I'd give you public holidays and Christmas off. And in return, you would work and you would do your best job. That was the contract. The reality now is the landscape we're seeing in workforce is that the employees have a very different expectation about what they want from us. And us running that model doesn't work anymore. So we really need to think about how we change the employee experience and the value of the employee inside Queensland Health. And unfortunately for health, sometimes what we do is we rely on this sense of mission or altruism. And the reality is that doesn't always compensate for what is sometimes an unbelievably difficult job to do. So we need to be untapping the employee experience and moving into a more modern arrangement. The next piece that I wanted to just briefly touch on is technologies. So when we think about technology, we need to find ways that have technologies that extend the intelligence of us as people. They help us do things faster, smarter, and allow us to spend more time doing other things of value. I often get really torn up in the health technology discussion because I feel like sometimes I'm in environments where people are talking about still building the flying car. I don't think we need the technology to have robots running around performing, surgeries and having this futuristic view. I think that we need to find very simple, easily implementable use of technology inside our health system that allows us to spend time doing what we're trained to do. And I think that's where we've got to invest our efforts, and technology will play a huge role in freeing up some of the time of our workforce. The other one that I would say is another key unlocker or a foundation that should be part of every strategy is around this term flexibility. So in Queensland Health, the general consensus is flexibility means work from home, and that's mostly available to non-clinical workforce. We really need to think about what flexibility actually means across our workforce, and especially with our clinical workforce. And it doesn't necessarily mean work from home. It may mean flexibility in rostered hours. It's looking at the way, for example, a nurse is engaged with us at Queensland Health. We know from speaking to our nurses that if we were offering a 10 till 2 shift 5 days a week, we would have a plethora of nurses that would sign up for those shifts every week. But we don't provide that opportunity. When we think about the flexibility, it needs to be broader. What we're hearing from our people is broader than work from home. It's things around childcare subsidies. I've been in numerous roundtables where the creche idea has been brought up of being part of Queensland Health or part of our facilities, so providing that childcare. We definitely need to, again, flex to more modern thinking and structures in relation to flexibility, as opposed to sort of playing the sort of line where, it's difficult for clinical workforce to work flexibly. The last one that's, which I would call an unlocker, is mindset. And again, this is unsurprising given my background, but I would say the largest barrier that we have in Queensland Health, or in health generally, is the mindset of the workforce in which we're trying to make the change. I have to be somewhat careful and pare back my opinions on this sometimes, especially in public forum, but I do think that the patch protection that we see between disciplines plays out in a way that isn't conducive to delivering services, and especially from a risk and safety and quality lens as well. And I've seen plenty of good ideas simply been turned away because the implementation of that idea would impact on the turf of another discipline. And I come back to that question of like, well, how much worse does it have to get? We need to ensure that we can find ways to actually change the mindset of how we deliver health, because without this change, nothing will stay. And it's very hard to get the change through. So they're the four sort of pieces that I talk about as being the unlockers that should be part of any workforce strategy. So in the final slide before we go to the panel discussion, well, what are we doing? Unsurprisingly, we are supporting and retaining the current workforce as our first point. We are building new pipelines of talent, and we're adapting and innovating new ways to deliver care, which is exactly like everybody else. I think the difference that we've got is that we are really embedding those four basic principles within and on all the actions that we're trying to do. So when we look at an action, we're thinking about it from a mindset change. We're thinking about it from an employee lens point of view. And we're hoping that through doing that piece before, the antecedent to the actual action, we're hoping that that allows us to get more buy-in and more stick, and getting that at scale. And that is really the challenge that we're wrestling with. So when we're thinking about supporting and retaining the workforce, you can see the three bullet points of where we're focusing. Where I prefer to focus is on the I statements underneath. I just think about our workforce of 125,000 people and think, well, if we had 80% of our workforce, or even 70%, I'd take 65. If 65% of our workforce could say, I have the skills and capabilities to do my work, I am safe at work, I have time to develop my career, try new roles, spend time with my family, and I'm proud to work here, I reckon we'd have a pretty good working environment in Queensland Health. When we look at the pipelines of talent, the real thing that we need to focus on is the significant challenges that we've got in our regions, rural and remote. I'm not saying that metros don't have a challenge, but our rural and remote area is definitely struggling, and we're seeing that. So we need to ensure that we have a really strong pipeline even before they come to you, all the way through to the school and getting them involved in health. We need the rural kids staying rural, studying rural, working rural. As someone from the Burdekin, close to JCU, I've seen how JCU have been able to really work that model when you look across the Townsville, across all the way to Mount Isa and up to Cairns. The model is if we have people who understand what it's like to live in Kowanyama or Billawheeler and study in our health programs, they will most likely go back and serve those communities. But we also need diversity in our workforce. And that also means that when we're thinking about bringing people into Queensland Health, we need to look at our First Nations workforce and say, well, does an interview panel actually work? Is that culturally appropriate for someone who's identified as First Nation? Surely there's other ways in which we can bring people into Queensland Health that don't ask people to foot straight into what have been predominant structures. And of course, on First Nations, my belief is that we need First Nations workforce across all levels, across all facets of the organisation, not just working in First Nation departments. We need a DG who is First Nations. We need a CMO who is someone who's First Nations. It can't just be putting First Nations people inside, First Nations departments or units. We need them across the whole level. And the last one is around the new roles, which is, I believe, our biggest opportunity. I think that we have a number of clinical workforce with scopes of practice that allows us to move that capability where we need it most, but without a risk to patient safety and quality. And I think that is where we really have the opportunity because 125,000 people means that we've got a huge opportunity to be able to meet clinical demand with clinical skill. And if we look at things purely as we will only have this role do this, then I think that we're limiting ourselves, especially if we know that pipeline behind that role is struggling. And of course, I mentioned about the technology. So I didn't want to take up too much more time, and I hope I've stayed somewhere close because I've not measured it. But that's what we're focusing on, and I'm really keen for the conversation, especially to hear from the experienced people on the panel. And I'll just leave Sisyphus up there just as a little reminder.
A reminder of the challenges we've got. Joe, thank you for that. That's just such a really clear account of the issues and the sort of way we need to be thinking about addressing this, pushing the rock up the hill. Just before I do go to the panel members, I just was thinking as you were talking, I was on a webinar the other afternoon where I was getting an update on the Commonwealth Scope of Practice Review and thinking about sort of like at the Commonwealth level, some of the reforms that are being tried, that are sort of being discussed and tried to push through. And I'm just wondering if you could talk a little bit about that Scope of Practice Review and what potential that Commonwealth strategies might have to interface with what Queensland's trying to do.
Yeah. If you're not familiar with the work that's being done, it's being led by Professor Mark Cormack, very, very esteemed leader in health. And effectively, it's looking at the scope of practice, effectively what I spoke about in relation to the clinical scope of practice across clinical roles and understanding what optimal scope of practice may be, where there's areas of overlap and where there's areas of opportunity to change health delivery and change health structure. I think what we're seeing with that is very much in line with our position in Queensland and what we're trying to push, as I mentioned. I think when you look at those elements, you also need to be acknowledged that at the moment, the Commonwealth and the federal government have a number of programs that are currently underway. There's the scope of practice, there's the Crook Review, which is around bringing people from overseas health practitioners, making it easier to come to Australia. They're looking at the levers around area of need and the district of workforce shortages levers as well, looking at Medicare. So I guess what the takeaway is, the scope of practice review is excellent, but what is amazing is that there's actually a plethora of programs that are underway. The risk that we have sometimes with these sorts of things is with large federal programs is the time to implement can take time. And in that time, people are still presenting at our facilities. So I very much welcome the direction the Commonwealth is taking with Minister Butler at the helm, but I also acknowledge that we also just need to get on and do some of these things now. And I think the scope of practice piece is something that we as a jurisdiction can manage already now with strong interaction with our industrial partners and other stakeholders. And it's things that we can implement without waiting for the review to come through.
Yeah, great. No, thank you. So I'm going to go to Amina first. So, Amina, again, a big emphasis on what role does technology have in helping us to sort of, bring forward some solutions. I'm wondering if you could talk a bit about what do you see as some of the opportunities that can be offered by digital health and technology, especially in settings both hospitals and primary care. Maybe if we start with that.
Thanks, Betsy, and thanks, Joe, for a fabulous presentation. He made my life much easier by just saying technology should make life easy. That's the best way you can explain all the complex work that we have been doing in terms of understanding how technology plays a very important role. I think in past 10 years or 12 years, we have moved from that phase where we were all excited about technology, started implementing large-scale electronic health record systems, and we have reached a stage where we are now looking at what doesn't work, what doesn't make healthcare workforce life easy, and how can we actually use it for better. And I think that's where I'm very excited that that's where technology should be. We all use technology in our daily lives. We know that a different model sometimes works better. It takes time to understand, but it does. So I think that's where we are at healthcare sort of spectrum at the moment, where we are trying to make sure that the things that we have implemented with such huge investments and efforts are really reaping the benefits that they should. For example, I think everybody who has worked on a frontline electronic health record system may have a bit of alert fatigue. Again, we understand that that has happened, but those alerts and those notifications were really made to learn over time. And now we are seeing a lot of benefits in terms of actually plugging off some of them and keeping the important ones. But we have worked also on building evidence on which alerts would work, where not. And that's the context importance that really brings or challenges technology more than any other domain. I haven't seen any other domain like health challenging technology. For example, you can't make a universal decision that one thing would work for all health services. And that's the most exciting part, that we are working with building evidence-based strategies, how to involve the healthcare workforce itself to make those decisions. And that's the fundamental. When we say that we want technology to make work easier, we need them to be the decision makers. But it's challenging, because again, we all get sort of a bit, I don't know how to program, or is it all about development? It's really not. And I think that's where we are at the moment, that technology is there. We just need to make sure that we are getting benefits from it. And I think this conversation, I don't want to take too much time, but would be empty if I don't mention artificial intelligence. And I know we are getting some exciting news that, AI is going to change the way we deliver. AI is not going to change the deliver. We are going to change the way we use AI to fundamentally improve the quality of healthcare. And that's probably the mindset that we are trying to work with frontline healthcare services to understand how can we actually translate and build that trust element with the technology, which is fundamental with those black boxes of AI. Again, I won't go into any details of machine learning, but just telling you it is a big, complex black box. But we are actually the ones creating all the data. We are the one not only creating data semantically or in words, with our actions, with our movements, we are creating data every day. That's feeding into those models. So I think if we collectively have that understanding, the promise is big. But it's just very important to understand that we need evidence-based strategies, and you really need healthcare workforce to bring all those skills together in those models, because they're empty without it. They really won't deliver if we don't do it. So promise is big, but we still have a bit of a way to go to make technology life easier.
So the people is still central to how technology is going to help. So just on that, Amina, can you also, because I know that you're also passionate about preparing our health workforce to be able to use technology in the way that you say to make their lives easier. Can you tell us a bit about some of the things that you think we need to do in our in the preparation of health professionals for the future to enable them to be able to use technology to achieve better outcomes?
Thanks, Betsy. Again, a very important question. I think the first thing that probably we need to understand is that it's not, one set of skills that comes with technology. It's not about understanding how to use it. It's understanding the philosophy. It's understanding why it is there. How can it help? Is it not even helping? And that requires a lot of confidence and trust in technology, which I think is the fundamental skill that we really need to build across the spectrum. So again, at QUT, for example, we are not thinking about technology as an isolated piece that can run as a one course, one-off course. We are trying to think, how can we actually build that trust, confidence, and skill base across most of the professional courses that we deliver? And I think that's where the fundamental strength of our programs will lie, that we will develop, as Joe was highlighting. Technology is not one part of healthcare workforce. It's going to be across the board. It's going to be the binding force. So we really need to make sure that our healthcare workforce has those at least fundamental skills. And it's again, as I want to really put emphasis, it's not about using the technology. It's actually a broad range of skills, starting to understand why it is there, how it is placed, how those decisions are made about technology, and actually how to communicate when it's not working. That's something that I've learned across my research a lot, that's something that's very important for healthcare workforce to raise their voice when things can be done better. And that's the expectation we need to raise. And that's where we have developed various skill-based courses, various sort of, and we have really embedded what we have found in evidence in that. Our research really informs by implementation science, which we felt when we worked across like last 10 years across various digital health implementations and healthcare services, that it's actually, again, not about the technology piece, it's how it's implemented, how workforce is informed. And that's where we realized that that's one skill that healthcare workforce would really benefit from it. And now we have embedded, those units, those learning elements in most of our courses, just because we understand the importance that it brings to the meaningful technology implementation. And also that's fundamental to building the confidence and trust element, which I cannot emphasize more. That's really the crucial part, where you need to have that confidence to have a conversation about technology meaningfully. We also know that technology brings exhaustion. Joe was already highlighting the exhaustion, being excited that, oh, my patient can use this app, or I can use this app. Imagine if you have 100 to use per day. Again, we all get exhausted by that. So again, finding that right balance and actually informing our upcoming future healthcare workforce to look out for that as well, how technology can be overwhelming on both sides, or entire spectrum of care. And I think that's also very, very fundamentally important, to build a balance between what technology can do and what not. And these are the discussions we really want to have in our day-to-day courses, day-to-day lectures. It's not like one-off conversation, it needs to be embedded throughout.
Yeah. Thank you, Amina. That's some great advice there. So Joe also spoke a lot about the need to transform, redesign the way in which health professional roles are established. I'm going to turn to Andy now. And Andy, as a pharmacist, I'm going to maybe just get you to talk a little bit about where you see perhaps pharmacy can contribute to addressing some of the challenges in our workforce.
Yeah, thanks, Patsy. A couple of things to pick up from what Joe said. Firstly, I can't agree more. Mindset is still a problem. And like Joe, I will also moderate my own thoughts in the public forum around this. But mindset is still a problem. And I think we need to continue to show a really strong commitment to interprofessional education, which we are doing at QUT. I don't have evidence for this, I only have personal experience. I've seen a huge uplift in the experience of the multidisciplinary team since interprofessional education was introduced into the undergraduate curriculum. So I think we need to maintain a really strong focus and commitment to interprofessional education. I'm delivering a unit with one of our paramedicine colleagues, Danny, at the back. I learned more about paramedicine roles and work environments last week than I thought there was to know. And so for the students to be learning this now, as opposed to me when I'm possibly a little bit further over the hill, is really valuable. And imagine a world where we didn't have other professions telling other professions what they can and can't do. I think that's what we need to be striving for. So scope of practice, that's one thing. The scope of practice review for me is a really nice body of work because it's looking at a systems-wide approach. Up until now, we've produced pharmacist scope of practice reviews, physio scope of practice reviews, nursing scope of practice reviews, which have all been brilliant bodies of work in isolation. What the scope of practice review is doing is looking at a systems-wide approach to scope of practice. And as Joe said, the really important word that Joe used was needs-based. So it's not advancing scope of practice just because we can. It's what the health service and what the patient needs and what profession can provide that service. Is it within current scope? If it isn't, how can we expand scope to be able to meet those needs? So I think it's a really valuable body of work and I'm hoping great things will come from it. From a pharmacy perspective, pharmacy has done a lot of great work over the last 10 to 15 years with scope of practice. And for scope of practice, I know this isn't necessarily a scope of practice forum, but scope of practice, I think people struggle a bit really understanding what exactly scope of practice is. And I've worked in the area since 2008, and I wasn't always totally clear until it was pointed out really simply that it's what you're competent to do, it's what you're authorized to do, and it's what you're accountable to. And those three things make up a scope of practice. It's no more complicated than that, really. So if you simplify it like that, it's nowhere near as hard, and scope of practices are dynamic. And so pharmacy has done some great work in scope of practice, as I say, over the last 10 to 15 years, and a few examples of that. Pharmacist vaccination is a huge example, and I would have loved to have seen the country get through the COVID pandemic without community pharmacy vaccination. 10 million COVID vaccines were delivered through community pharmacies. All of those vaccines would have had to have been delivered elsewhere, or possibly not delivered, had community pharmacy not had the capacity and the capability to take on vaccination. And that was a whole body of work looking at scope of practice, looking at what the undergraduate curriculum prepared pharmacists for, looking at the immunisation standards of practice and what was the gap. And what was found that the only gap really was the administration of the vaccine. And so there was training provided to pharmacists to be able to take that on as at the time as an extended scope of practice. Now that's been, and where pharmacy programs need to keep up is we need to be looking at what we can embed into the undergraduate curriculum so our graduates come out workforce ready. And at QUT, we've embedded vaccination training into the undergraduate curriculum so our graduates come out as interns, able to vaccinate under supervision of a generally registered pharmacist. And so with that uplift in access to vaccines in the community has been a huge asset to the health and well-being of the community. UTI is another example, and now any lady between the age of 18 and 65 who believes they have symptoms of a urinary tract infection can present to a pharmacy in Queensland, be given a diagnosis and be given antibiotics on the spot. So again, reducing the amount of patients who need to go through the GP system, which we know is already totally overwhelmed, hopefully reducing the amount of patients who need to present to the emergency department because they haven't caught the symptoms early enough. And we're currently heavily involved, QUT are currently heavily involved with delivering the education to the pharmacy full scope project, which is again looking to uplift the scope of community pharmacists. Now it started off in far north Queensland because again, from a needs base, that's where the need is greatest. There are some areas in far north Queensland where it can take 8 weeks to get an appointment with the GP, and if you think you've got an acute presentation, an acute problem that needs sorting, and it takes 8 weeks to get an appointment with your GP. So that's really looking at community pharmacists being able to treat more and trying to avoid the patients having to go through to the GP, maybe emergency department. Again, there needs to be an uplift in the competencies because pharmacists aren't trained in a number of things at an undergraduate level to be able to take on that scope of practice. So there has needed to be extra training. But I think it will be extremely valuable for the health system. It will free up capacity within the GP system, and it will provide greater access to safe and effective medications for the general public.
I think that's a really important message because I know when we talk about some of the changing ways in which we're delivering healthcare, you know, we should be very proud in Australia. We've got, you know, one of the safest and best healthcare systems in the world, and we hang on to that, but sometimes that sort of means that we're a little bit frightened about sort of trying new things because no, it's not going to be safe. But I think, as you say, as we see the evidence, we see that, you know, that these practices, some practices can be done very, very safely. Because I also worry when we, you know, sort of hide behind that safety thing when we've got people who actually aren't able to access a health service. Well, that's a safety issue too, isn't it? So
and no one
getting
wants
that balance, isn't it?
Yeah, and no one wants to extend scope of practice into somewhere that's unsafe for anyone, for either the health practitioner or the general public. And pharmacist prescribing, I think, is the last thing that we just touch on. That's been a large body of work for a large number of years now. And again, pharmacist prescribing standards have now been produced. We have a course at QUT that we hope will be accredited very soon. And it's now about where the future of that is. We're working with ACAHO to develop guidelines for partnered prescribing in hospital. And we've finally called it prescribing, which is been one of the biggest barriers for many years. I sat in a workshop in Melbourne in 2010 trying to work out what should we call it apart from prescribing. And in the end, we decided to call it prescribing, because everything's become so weaponized in this space. And so we are working on partnered prescribing for hospital. We will hopefully be embedding prescribing competencies and prescribing standards into the undergraduate curriculum sometime soon.
And as you say, all in the context of that whole interprofessional approach too, is you know, so that's great. Well, thank you, Andy. That's really interesting. I'm going to move to Suzanne now. And Suzanne, a nurse practitioner. So, you know, I was here at QT when we introduced the nurse practitioner program, the first nurse practitioner program in 2000. And I remember, you know, there was a lot of excitement and a lot of interest, and we were overwhelmed with applications in those first few years. But then that started to decline. And because we had this sort of mismatch, I think, between the readiness and the aspirations of the nursing profession and the healthcare environment out there for these roles. And so it sort of took a bit of time to slow, and now there is, again, a great uptick in interest, and we know that we've had huge demand this year. And just last night I was at a College of Nursing function where local directors of nursing saying, where are those nurse practitioners? You know, we need to talk to you, where are they? So Suzanne, you know, it's had an interesting history, the development of nurse practitioners in Australia. So I'm going to maybe ask you to talk a little bit about where do you see the potential for nurse practitioners in the future in this environment that we're talking about, and how can we really continue to grow and support the role of nurse practitioners?
Thanks, Patsy. You're right. Nurse practitioners have been in Australia since 2000, so for more than 20 years. And I guess for those of you who aren't familiar with that role, nurse practitioners are registered nurses who have extensive experience in their area of specialty and are working at what we call an advanced practice level, so to the top of their scope, and then go on to do a Masters of Nurse Practitioner and become nurse practitioners. So nurse practitioners can assess, diagnose, prescribe, manage a patient independently, but also work collaboratively with other health professionals. So in Australia at this point, even though we've been going for 24 years, there are only about 2,700 nurse practitioners. And 700 of those, or a bit over 700 of those, are in Queensland. I think at the moment, you know, we're doing pretty well. I've actually written a list. When you think about nurse practitioners and where we're working, when we first started in the 2000s, we predominantly worked in the emergency department setting, and it was seen as a way of improving access to care in that setting. But now, this year, I can say quite confidently, nurse practitioners are working across the priority areas of healthcare for Australia and are working in diverse areas. So here's my list. So we have nurse practitioners in cardiology and respiratory nurse practitioners, cancer, gerontology, surgical, perioperative, nurse practitioners who have learnt to do robotic surgery and assist surgeons, medical, neurology, oncology, women's health, including fertility practice, men's health, orthopaedics, paediatrics, urology, and there's a lot of nurse practitioners in preventative health. So, you know, you can see that we've really expanded in terms of the services that we can work across. In Queensland, I think, Joe, about 40% of the MP workforce work in Queensland Health, and the rest are out in primary healthcare and working in collaboration with general practitioners and working in primary healthcare, and working in other areas of private health, in private practice, and palliative healthcare, for example, is a fast-growing area of nurse practitioner practice, as is aged care. So we're actually starting to expand really well, and I think we are developing, you know, our scope of practice and actually maximising our scope of practice, but we have a long way to go, and that is because we're just not actually training enough nurse practitioners. So I think that as MPs have the ability to fill a lot of those or improve access to care across public and private and community health, but we're firstly probably an untapped workforce, and often in the public health system we're not working to our full scope of practice for many reasons, be it territorial or cultural or a lack of understanding about the MP role. I would say that the nurse practitioners aren't well integrated into the healthcare landscape. We tend to sit beside nursing and beside the medical team rather than being integrated into that team. So there's a lot of work to be done in that space. But, you know, there's so much to offer. But one of the key issues is that whole pipeline to actually grow and develop nurse practitioners. So at QUT, we have the largest cohort of MPs MP students in Australia, so we've got just over 200. There's only 14 universities offering Master of Nurse Practitioner Australia-wide. And we do now have a 10-year workforce plan for nurse practitioners, and there's a lot of support from the federal government. There's been recently been $50 million investment in training nurse practitioners, and also in improving our access to MBS, especially. At the moment, nurse practitioners in Australia have access to 4 Medicare item numbers, only 4, out of all the hundreds and hundreds of Medicare item numbers that there are. So MPs working in private practice are quite limited in terms of, being economically viable and what they can offer patients. So there's a lot of work to be done in those spaces, but I think certainly the federal government is looking at that now, and that will be really, will make a huge difference. But as Patsy is saying, and I've talked to lots of executive directors of nursing recently, and they're looking for MPs to help support their workforce. And as a way of improving access to care and filling a lot of gaps that are in the work, a lot of spaces for extra healthcare professionals. But to do that, we're actually needing to look at that pipeline right from when, like from education and health. What we probably need is to look at aligning how we're training MPs in the tertiary level, in the tertiary system, and how that can be synergised with public health. So really, at the moment, the way, experienced nurses want to be more autonomous, they want to expand their scope, they want to be more independent, so they think, I'll become a nurse practitioner. And so out of the 125 or 200 students that we have at the moment, probably only about 30% of those students are actually supported to do that study in their health service. So they pay for their own fees, and then they have to do lots of supernumerary clinical hours to become nurse practitioners. That's part of the accreditation process, but they're doing that in their own time. So they're really highly motivated, really driven nurses who want to be able to work at the top of their scope and provide care in their area of specialty, but there's not much support out there for them. So whilst we can actually, I think, fill a lot of those gaps and are an untapped workforce in the public and private health systems, we need a lot more support in terms of supporting nurses to become nurse practitioners and aligning that with the health, with what's happening in the actual public health system. So I guess what I mean by that is, at the moment, we wait for people to say, yeah, I want to be a nurse practitioner, and they may or may not have support. But we could probably look a bit deeper at that and start looking at an MP pathway for interested nurses, like from the undergraduate level, but also align that with how they're doing their progressing their pathway in the actual healthcare system. So
Suzanne, just really interested. I mean, you talked, and I think you're right, it's this whole thing about how is this integrated within the way in which we deliver care. And so have you seen somewhere where it works really, really well, and what are the ingredients of that? Because that's the sort of thing we need to sort of know, where it does work well, where the role is integrated, how can we scale that? What are some examples?
There's a lot of places it's working really well. A lot of diabetes, for example. There are a lot of diabetes nurse practitioners working privately in the community, in the private health, in primary health care, who are highly accepted by the medical specialists that they work with, and who work collaboratively to provide care. And with the medical specialists and the general practitioners, they can sort of provide that interim care, which reduces how many times the patient has to see a specialist, and also makes the care sort of more consistent and streamlined, so they can actually look after the medications and so forth, but then send them back to the specialist when they need that bit of tweaking. Palliative care is another area where it's working really well. There's a lot of palliative care nurse practitioner teams who work with palliative care specialists and are able to provide that consistency of care and see patients more regularly, and then consult with the specialist when it becomes a bit trickier or a bit more complex. So in those kind of systems, it's working really well. In the emergency department setting, some models of care are working well where MPs are enabled to work to their full scope of practice, but we do have a lot of emergency care settings where MPs are confined to fast track, which is basically seeing fairly simplified things. So in those cases, we have our nurses who are actually at the top of their scope, who are highly experienced and can manage far more than just basic fast track. who become de-skilled over time because of and that is often a cultural or territorial issue.
Okay.
So I think, those private practice areas are working really well. Orthopaedics in private practice, for example, there's all the orthopods working with nurse practitioners, and the nurse practitioners actually do all that really important holistic healthcare. They do the assessment of the patient when they first present. They assist with the diagnostic testing and interpretation of those tests, and then they will actually go and work in surgery. They'll actually be part of the surgical team when the patient has a surgery, for example, and then they will follow that patient up post-operatively and when they're at home, and manage their pain care and their ongoing recovery.
Okay,
so that's a really good example.
So again, so it sounds like it's around collaboration, but also really patient-centred, and what are all the bits that are really focused around how do we work together to really address this patient's needs. So thank you, Suzanne. Jo, I'm just going to, before I go to Christine, because I want to sort of get Christine's thoughts on, some of the challenges our students are facing at the moment. But Jo, one of the things which we haven't spoken about, but you raised it in your presentation, are really important about the First Nations health workforce. And I'm interested in, what's Queensland currently doing to sort of develop and retain and support First Nations workforce, and what more can we do in that?
So First Nations is a key area of focus for Queensland Health. We have invested a lot in our Deadly Starts program, which is basically the high school traineeships where First Nations kids have access to Cert 3 and Cert 4s through their grade 11 and 12 or grade 10, 11 and 12 sort of years, and they've got guaranteed employment in Queensland Health once they get through. So that is, and then there's obviously the support around it. Once we get into Queensland Health, this is where it gets trickier. And Haylene Grogan has been a real leader in this space on how we make, she says, First Nations first. And I can tell you very clearly, workforce is important. The next thing that comes out, or either one comes first, normally is First Nations. And so the things that we're looking to do inside Queensland Health are, for example, we've developed a First Nations leadership program, which is a First Nations program which is delivered by First Nations people, which is set in the context that supports First Nations people to grow the leadership skills inside the system. We're also at the point where we ran the pilot a couple of years ago. It's across about 16 HHSs now. And we're also looking at the opportunity to include the community control sector in that training as well. So when I think about the things in First Nations, there's a lot of push to ensure, like I said, that we're not looking at a quota, we're not looking at numbers, we're looking at how do we create environments that attracts First Nations people to health, but also provides them with pathways inside health to pursue options and opportunities that are open to all. And so that's how Haylene in particular is cracking that egg. And we have a long way to go, like a lot of society when it comes to First Nations, but it is a key priority for the DG and ELT.
Yes, Haylene was here last week and part of our Indigenous Health Planning Day, and really provided a great context for us. And in fact, our last Real Health lecture at the end of last year was on Indigenous health issues, and we, again, we're really trying to work with our Indigenous colleagues and with leadership in Jo and Jodie and Angela and Deb Duthie around, again, how can we sort of tap into maybe some other pathways for education based on some of those things you're doing. So
we try really hard, like with the health practitioner role, and
yes,
that's something that we're looking to grow. It's a very small workforce. We know that they play a critical role in care, especially in our rural and remote locations. But that's another example of a role that may look and sound a bit like another role that has had challenges to get implementation in. But if you look at it purely from a needs base of First Nations people, access to care and comfort with joining our health system, a health practitioner is a very good way that it provides that comfort and safety for a First Nations person to health.
So Christine, has done a lot of work and led a lot of conversations nationally on this concept of, what's become known as placement poverty. So I'm wondering, Christine, if you could tell us a little bit about that and what you see as some solutions to that.
Sure. So we did a national study looking at social work practitioners, educators and students, and the data from students was particularly devastating in terms of what was going on for them while they're on placement. And that's where this notion of placement poverty emerged from. So we know that students are having to give up paid work in order to do placements, and the way that health placements are often structured is in large chunks of time, which does often force students into poverty. And so the data was indicating that 96% of our social work students nationally, of those who responded, are struggling to afford food, struggling to pay for basic medicines, basic necessities. They are choosing to, have petrol to go to their placements or to buy food. They are having to give up their rental properties, which is a real problem in the context of a housing crisis. Some of them talked about even going to live with their parents, even when their parents themselves, mature age, losing their independence, which was, a really frightening prospect for people. We know that people are going into large debt, taking out big loans, maxing out their credit cards, going without lots of basic necessities, as we said. We know that, there were all sorts of kind of really tragic examples. People, there's another cohort of students who simply can't afford not to work. So they're the ones who are working 60 hours, 80 hours, working outside on top of their placements, cleaning rooms before they go into their placements, maybe doing night fill in supermarkets or driving Ubers at night. They're the ones who are not getting sleep. They're going into their placements, basically scraping themselves through the whole experience, not learning what we need them to learn, of course, because if you're, that exhausted, then your capacity to learn is obviously diminished. And there were hidden costs in terms of placement as well. Uniforms, parking costs. Somebody was saying that they were paying $80 a week parking in a hospital. Somebody else had racked up a $6,000 childcare bill that that they couldn't look after their kids because they were on placement, and so that was an additional expense as well. So I guess what we're seeing is that this is particularly devastating if we're wanting to attract, equity groups into our professions. It is becoming a situation where only wealthy students can afford to study. And so, we have a situation where we're excluding large, parts of the population, I guess. We do know that unpaid placements act as a disincentive for students to enrol in degrees that require placement, particularly those from equity backgrounds. But we also know that students defer placements often to the last or drop out. So, there are attrition issues as well, which has really serious implications for, the workforce shortages that we've been seeing throughout the situation.
So if you had to say one or two things that could be done, what would they be if you were a policy,
Yeah, so I think, paid placements are the ultimate goal, and the Australian Universities Accord has recognised that unpaid work is an issue for our students, and that, students should be paid for mandatory hours that they're required to do on placement. So that's one of the recommendations of the Universities Accord, and hopefully the Minister of Education will be looking closely at that for the May budget. It is an urgent priority. So that, I think, would be really a game changer in terms of, I've already had people contacting me saying, when is this coming in? Is it coming in? I've been wanting to study for years. I've been putting that off. I would enrol tomorrow if unpaid placements. And the other thing I think is that accreditation bodies could look at the hours that are being required, perhaps without evidence. I know in social work we require 1,000 hours of unpaid work. There's no evidence base to justify that amount of hours. We now have evidence to show, because of COVID, that students could demonstrate required learning within 800 hours. So there's, an argument there to reduce hours at least for 20%. I think greater recognition of prior learning that students come with, would be important, and also the capacity to increase flexibility around work-based placements and so on, because there's those things are prevented at this point in time.
Thank you, Christine. I mean, they're really sensible, sort of, so they'll sound easy, but again, we know those are going to be some really contested debates in some of these areas over the coming months as well. Well, thank you. It's been a really interesting discussion, and I'm conscious that we are running out of time, but I do want to give a chance just for a couple of questions from the room and maybe one or two online. Anyone in the room has a burning question? There's one right up at the back there. Thank you.
Hello. I'm really interested, Patsy, when you mentioned that Australia does things very well, mostly in healthcare, and there's maybe one or two things that we're a bit scared to do because we're just not sure about. I am a paramedic, but I'm also a nurse. And something that I know is currently a hot topic is the capabilities, and in terms of scope, Andy, you mentioned that often the barrier is, when you break it down, there's capability, training, and authorization. So the capabilities of paramedicine to work outside of just that traditional ambulance setting and into primary health care, where we could complement and potentially take away some of that burden. But then there's the patchwork turf wars that sometimes come with that. And of course, a lot of policy and legislation that restricts that. So in terms of a systems-wide approach and potentially trying to focus on, is there much in the way of, within Queensland Health, figuring out whether or not paramedics could be utilised, or even dual registered paramedic, nurse, midwives, all the rest of the other workforce we have? I'm really interested in knowing any more information you might have on that.
The short answer is yes, and I would put absolutely underlined it. It's been one of the things when I came into Queensland Health, paramedic workforce and, quite controversially, physician assistants have been two roles which we have progressed relentlessly. I think there is a huge potential in the paramedic workforce, especially when you think about the number of people graduating from paramedicine and then the number of roles that are available inside, say, Queensland Ambulance Service. Paramedics have unbelievable clinical skills that are applicable in settings beyond the traditional. We're seeing that in Victoria. We're seeing paramedics working in aged care, in community care. And also, if you think about overlaying, the reason why the paramedics, without getting into the industrial and legislative barriers and the award issues in relation to Queensland Health, which we're working through, you just think about the career. Let's go back to that principle of the career of somebody and what their expectation is. When we talk about flexibility, you know what flexibility could look like? A paramedic that works on the road, is on the road for 12 months, and then says, you know what, I really enjoyed that, but I really want a different pace. I want to go work in community care. And then they work in community care for 6 months, and then they come and work in a hospital for 6 months. That's called work flexibility, and that gives people the time to recharge, retrace or redirect their effort and move around. And that's how we keep people in the profession, because if we keep people on the road for 15 years, that gets really hard. So we are 100% looking at it. It's a very good question. I'm very passionate about the paramedics, and watch this space.
Okay, thank you.
Thank you.
Another question here, and then we'll go to Jody next, and then we'll take one online after that.
Thank you. Great panel presentation this morning. My question is probably more to Jo, Jen Nancaro from Queensland Health. Along the lines of regional workforces, so you've talked a little bit about that. We've also talked about placement poverty. Have there been any thoughts around healthcare families as such, so clinicians who are married to other clinicians or other people who work, or don't even need to be married, partnered, within the health workforce? There are many situations where the clinician may get a job in a rural or regional area and the partner or the family member can't get a position. So you're basically forced to leave for financial reasons more than anything else. Do we look at that from a statewide perspective?
To some extent, I think it's an interesting question, because the regional and the rural remote workforce shortage is really challenging. And what I believe I know from the data and evidence that I've seen is the relocation of somebody from southeast corner to a region is not a solid pipeline. It happens, but it's not where we should be putting our chips. We need to do two things concurrently. We need to grow, like I mentioned, the workforce in and around those environments. And the other thing that we've got to also do is that we also need to start to create these regional places as really big attracting hubs of where people want to live. And I'm talking down the track here now, but we need to see Central Queensland, North Queensland, you know, when we start moving in west, we need to start seeing these places as these big sort of building metropolitan areas where people want to go and train, where people want to go and live. And the way that we do that is by creating the system, the ecosystem now through growing the workforce there. It's a wicked problem. The reality will be, if we don't manage this, what will likely happen is we will have oversupply inside the metro areas, and we will then work on a networked model where surgical services, all types of services, are absolutely flown in a more structured way than they already are. And the likelihood is we'll probably move down that model in the time it takes to actually build it. But I think that we need to create, you need to create Townsville, Cairns, Bundaberg, Mackay. These have to be places where people want to train. And the reality is the clinical experience that people get in these locations are phenomenal. You know, you hear about nurses who go work in the north and they see incidents of disease that they will never see at the RBWH or and the opportunity is huge.
But I think we need to think about the partner or the family member that's attached to that unit as well. We miss that totally.
Yeah, and sometimes, a lot of clinicians marry clinicians, but also we have a lot of nurses who marry police officers. So there's also a lot of other departments that play a role, teachers. So I think you're right, looking at making something attractive for a family cohort is worthwhile looking at.
Just take Jodie Curry here. Just walk down the front. Thanks, Tim. Then we'll take one question online and we may have to wrap up.
100 things, and thank you, what a wonderful panel. My question is probably to Amina and Joe, but taking on board everything that everybody said, particularly around scope of practice and where this begins and ends. You're going from primary healthcare through to tertiary, and whether, you know, the role of social workers and psychology in relation to overall well-being. To the point about AI and technology, we in health tend to go to this thing about, you know, notes, assessment. It's really clinical-based things. Do you think, and probably for all the panel, that what is the opportunity for AI and technology in actually articulating our mission and our vision for why we want people to come into healthcare? It's very much in the clinical model, but we all know you need to support the individual. Do you think that we're thinking about AI or utilising that to articulate our mission or values?
Amina.
Mm-hmm.
Sure those online can hear as well. What I think is it's more, what you've said is that should be a global vision. Really, it's not, you know, healthcare is definitely. Where AI stands is that we have had the complexity where it has emerged way too rapidly in many things that we are seeing now, that we are now taking a step back and suddenly questioning the ethics, the privacy, the responsibility, the inclusiveness. And we also know that there is a lot of reliance on the data that goes into these models, which don't sometimes create those values that we are trying to project. But it also demonstrates that model works, but it's the data, it's the human social element that hasn't lived to its part. And that's where I think that's why responsible AI, responsible ethics is such a big conversation, and health is really going to lead it. Unfortunately, apologies to anybody in robotics or engineering. I'm a software engineer myself, so I think I lost my half audience here by saying that. But if you ask me as a software engineer, my training was very different. I shouldn't be saying this, but ethics is not like the first topic I'll study. I'll study about the exciting technology, whereas health is very different. After working here in 20 years, I see priorities are so different. So I do think that that's exactly what we need to achieve with AI. And actually, humans can't scale to that level where technology can. But it only would work if the data or the input that is supporting into those systems is constantly questioned and built with those ethics and value. But we can actually deliver it using technology. So I think the back end is the human power that we need to build. And that's what we all need to work towards in all disciplines and all like beyond, I think it's way beyond like one even territory. It's a global universal question that we are going to ask because the systems that we are going to use are going to be universal. It already is, by the way. A lot of systems that we are using here in Australia, hospital-wide, are actually implemented in the US, implemented in the UK. We learn lessons globally as well. But I think with AI, the only fundamental thing will be the pace at which it can outpace some things as well. And unfortunately, it also has the capability to get to build information now as well. We all know that it can create, and it can create in such a convincing way that we won't be able to doubt it. So I think that's where we really need to work hard in health to make sure that whatever goes in is authentic, is representative, is inclusive, because that's the value that we want to build in healthcare. And that's where I think we have such a long way to go. Because again, our models probably, the way we were working, were not ready for the pace with which AI is outpacing. It has the potential, but we have to build it the right way.
Great question, Jodie. Thank you. We'll take one question online before we wrap up. Yeah.
Thank you, Patsy. I have a question from Professor Jane Phillips, Head of School of Nursing. She has asked to hear from Jo on how we can prepare the current workforce for a more internationalised health workforce, both overseas trained as well as locally educated professionals, so that this talent is welcomed and effectively utilised.
Thank you. That's a very good question. I think what we're going to see is the reason why the question is so pertinent is we are going to see a lot of international workforce come to Australia to work in our settings, and as a result, one of the things that sometimes we don't do that well in Queensland Health is with our IMGs, but also our international health practitioners, is we don't really indoctrinate them into Queensland Health, right? So. And what we see a lot of as well with some of the cultural differences is even something as simple as language. Where we see a lot of things breaking down is in language, where we might say, oh, he's cactus, that one, right? And if you're somebody who's not from Australian culture, what does that even mean? And you probably have an understanding of what a cactus is, but you don't understand the context in which it's worked. So we actually really need to be more inclusive, because the reality is as well, a lot of our international graduates or international health practitioners are coming into the regions. Some of them come into the metro, but the majority is they're happening up north. So we need to ensure that not only the education of our domestic students understand what it's like working with diverse populations, but we also need to help people come into the system to feel welcomed and secure. I think that there's a lot of work to be done in this space, and I think that if we are creating a diverse workforce inside Queensland Health as we go, that is going to create the platform. It will happen organically through that process, but there will need to be some dedicated effort on how we actually make that a reality, because what we'll have is workforces within workforces. And we know that there are some nations that are very openly talking about health workers as an export. And we also need to be very, very careful in Queensland Health, or in health generally, where we do not want to be robbing Peter to pay Paul. While we are going badly, there's other places that are going far worse, and we cannot be seen to be taking that workforce from other nations that need them, if not more than what we do. So it's a good question, but it's one that we will probably tackle with some time.
And I think you're right. There's a lot to be done just to that sort of just inclusiveness for and diversity, isn't it? Look, we unfortunately have run out of time. We've only really just touched on so many issues, and I know that there's lots more questions that we haven't even addressed. Disability, inclusive work. So many things we could address. But I think what we've heard today is while there's many, many challenges, there's so many opportunities we have at this time to really push through some things that may have been thought about in the past and sort of all just too hard to do. I think we're in a bit of a time where perhaps there's a bit more alignment and willingness to really achieve some of those strategies that were on Joe's slide earlier. So I just want to say thank you so much to everyone on the panel for, great conversation. Please, I'm sure that anyone on the panel will be happy to, if you didn't get a chance to ask your question, and online, we might sort of filter through some of the online questions and send it to some of you individually, if that's okay. But yeah, we are really proud here at QUT of our contribution to really addressing the health workforce challenges of the future. So really look forward to working with you all in terms of how we shape and contribute to some of those pillars there. And we also didn't get to talk about the work environment and how we can actually help do research and so many things we could keep going on about. But thank you all, and thank you in particular to Joe for that great presentation to set the scene for us and open, honest conversation about how we might work together in the future. So join with me and thank you. I should also just note on the table, you'll see QR codes. If you just want to scan that, you will, just get on the mailing list for future lectures. And the next one is on June 6th, I think. Don't quote me on that. It's in early June anyway. I do also want to thank the team who've do all the background work to pull this together, in particular Kari, Tiffany and Rachel, but also all the others in the Dean's office who've helped with that. But thank you also everyone for coming along. Thank you online, and we do look forward to working with you in your respective roles in the future. Thank you.